So what I'm going to do with my time is tell you a little bit about my story, how I learned about ALS and how I learned that we needed a CRLI, Clinical Research Learning Institute, what we've accomplished with it so far, and what we hope you will accomplish moving forward. I think anytime somebody gives you a scientific lecture, they should tell you where their money's coming from. I'm not actually receiving any money for giving this lecture, but I do have other sources of support. So I have research support from the ALS Association, the Healy Center, and a company called Medicine Nova. And then I've got consulting support from several different companies. Mostly what I do for these companies is I try to help them design more patient-centric trials, but I also do some data safety monitoring boards to try to help them make sure that there's no safety signals that would require a modification to their protocol. I don't think any of these disclosures really would influence what I have to say here in this talk, but I just want to make you aware of them. So I first encountered a person with ALS in the late 90s when I was still a resident at Duke. And you can tell that picture is from the late 90s for two reasons. One, I had the Jerry Seinfeld haircut. And two, that's the only time in my life when I ever wore blue blazers. Duke was a very conservative place back then, and I was trying to keep my head low and not create any waves. And I still remember how amazed I was by that person's story and by the collection of physical findings on their exam. And I also remember how terrible I felt when my attending came in and said, "We know what this is called, but we don't really know why it happens. And there's nothing we can do about it. You just have to go home and get your affairs in order." And I just felt so helpless. I could only imagine what that patient and family felt. And I think it was that day that I made the decision I would stay at Duke and try to build a program that would offer people options and a research arm of that program that would offer them some hope. And so, I didn't really have an ALS mentor at Duke. And thankfully, early in my career, I found some great people. Terry was one of the first people that I bumped into who sort of took me under her wing, showed me what she had built, and I tried to replicate it. So I built also a large multidisciplinary clinic at Duke. We have roughly 19 clinicians working together now. And, like they do at the ALS Center of Hope, what we try to do is each person sees every patient when they come in, and each person has a few jobs. They measure a few parts of the body. And if they see that ALS is trying to take something away from one part of the body, then they're trained to offer people options for compensating so they can live the best life and the longest life possible with this disease. And we built a research arm. And in the beginning, we were doing mostly clinical trials for companies, but we've really expanded. We do genetic studies, biomarker studies, all different kinds of clinical trials now, including our own investigator-initiated studies. And the clinic has really grown. We went from probably 7 or 8 patients total at Duke back when I was a resident with this disease to about 500 patients that we follow in our Duke ALS clinic. We see about 250 new patients per year. So about 5 years in, I was sort of looking back over this and I was really proud. I said, I don't think anybody could do any better than what we're doing here at Duke right now. And then I saw something kind of surprising. I started to look at the percentage of my patients that were enrolling in the research trials that we offered. And I found that it was really low. It was like about 5% of the patients in my clinic were enrolling in research. And as I surveyed other people with larger clinics at the time, they all noticed the same thing. Looking at this a different way, as we scan through the literature on clinical trials that have been published in ALS over many decades, the trial enrollment rate was about 2 patients per site per month. Now, most of these were big ALS clinics in these trials, and they would see anywhere from 40 to 80 patients in a month, and they were enrolling 2 in a clinical trial. And the other really sad thing was that this wasn't changing much over time, over several decades of publications. And so this, to me, was a huge problem. Because first of all, it meant that patients were being deprived of the benefits of being in clinical trials. And there's lots of benefits. So some of you that have participated in trials, you found probably benefits of hope from being in a trial. You found benefits of altruism feeling like something good is coming out of this bad thing that happened to you. But you may not know that people who participate in clinical trials, no matter what trial, no matter what disease, no matter whether they got a drug or a placebo, they appear to do better medically compared to people who don't. It's not that surprising, because for those of you that have been in trials, you know, you often get seen a lot more frequently. There's a lot more measurements made in a trial than there is in a typical clinic. And so we probably pick up on things before they become more serious, and we can be more proactive for people who are in trials. Other problems with this, well, the trials that we do, they're going to take longer to enroll. They're going to cost more. There are actually multiple examples in the history of ALS where we had to stop a clinical trial because we just couldn't enroll and we never got a conclusion. And then maybe the most disappointing one of all is that if we enroll such a small percentage of the patients that we see in our clinics and we find something that works, how do we know that it works in the other 95% of people who either couldn't or wouldn't be in the clinical trial? And so to me, I mean, unless we could solve this enrollment problem, it was going to take us longer to find a cure for ALS than it should. And that just isn't acceptable to anyone. And so I put out some surveys of patients, surveys of different types of clinicians to try to understand this enrollment problem better. And it turned out this was just really the tip of an iceberg. So there were multiple issues with the ways that we were doing research back in the early 2000s. The biggest one being that patients were considered subjects. They weren't considered partners. And there's just a big disconnect there. You know, when you think of patients that way, you know, they may be unaware of the types of research that you're doing. They may have misconceptions about the types of research that you're doing. They may not understand the preclinical models, the small effect sizes that many trials are looking for, the restrictive inclusion criteria, the use of placebos, the reason why trials are so burdensome, or the long time that it takes for us to get results. And as a result of this disconnection, I just found that a lot of patients preferred to self-experiment. They would just buy and try things that they read about on the internet, things that I called alternative or off-label treatments. And there was a lot of frustration that doctors were not more interested in these. The other problem, of course, was there just weren't enough options to go around. Even now, when we feel like there's more research than there's ever been, at the end of last year, there were about 2,000 total spots in the ALS clinical trials that were open in the United States. There's probably 20 to 30,000 people living with ALS. So even if everybody wanted to be in a study and qualified for the study, there wouldn't be enough spots. So I started to think about how to improve engagement, how to make patients partners. And you know, some of the concepts that I actually heard from patients back then that I was interviewing, one of them was nothing about us should be done without us. And that sort of became my mission since those early years. And then the other one is we're better together. And I still believe that to be true. And so I looked around at other fields that might be embracing those themes. And I found that they were doing a really nice job with this in Parkinson's disease. So they had a program that they called Clinical Research Learning Institutes. They were training programs. They would bring patients and family members in. They would fly them in back then. This was pre-pandemic. And they'd spend a couple days learning about the research process, getting a vocabulary to be able to be full partners, and finding places where there were opportunities to influence and improve it. So from the Parkinson's Research Foundation website comes this really nice diagram showing all the different places that the graduates of their programs, which they called research advocates, have been involved in research since they started. So they're helping develop better study concepts. They're helping secure more funding. They're helping sponsors to make more patient-centric protocols and procedures. They're helping, as the study is opening and enrolling, to spread the word about it, to look for problems that they can improve upon. Once the study's done and there's data to analyze, they're helping sponsors to understand maybe what that data means to patients and how to craft a message that will be meaningful to patients. And then finally, they were helping regulators like the FDA to understand what an acceptable risk benefit might look like for a person with Parkinson's disease. And so I was so impressed with this that I decided to try to recreate it in the ALS field. And I'm happy to say that with a lot of help from people like Terry and the ALS Hope Foundation, Niels, Allison, Nadia Sethi, this program has really grown. So we've now had 21 clinical research learning institutes. And as you can see, they're starting to spread not only across the United States, but into other countries. And we do much prefer to have these in person if we can. That picture is actually from the last in-person Clinical Research Learning Institute, which was in Clearwater, Florida, back in 2019. But we've learned that we can do them virtually with the new technology that we have. And with all these Clinical Research Learning Institutes, we've now trained more than 500 graduates, which we now call ALS Research Ambassadors. And so this is not over for these graduates, these research ambassadors, when the CRLI ends. We've created something within NEALS, the Northeast ALS Consortium, called the PEACE Committee. That stands for Patient Education and Advocacy Committee. And as you heard from Allison earlier, she and Nadia Sethi now lead this. So some of the graduates of our early CRLIs have now taken the lead on the PEACE Committee. And everybody that graduates from a CRLI is considered to be a member of the PEACE Committee, as are all NEALS clinicians. How does this work? Well, right now what we do are monthly video conferences, and we invite stakeholders from all over the ALS research space to come and present projects which are in need of input from trained patients and family members. And so these might be patient advocacy groups, these might be sponsors, these might be individual researchers. And as a result of all of these talented people with all this training and all this connection, we're seeing some incredible efforts. So first of all, we've seen some amazing increases in research availability. And part of that is fundraising. So graduates of this program have played key roles in raising literally hundreds of millions of dollars for ALS research. These two guys in these pictures right here, Pat and Pete, they were graduates from one of our first CRLIs, and they went on in 2014 to start the Ice Bucket Challenge. And I don't have to tell you what an amazing success that was, both in terms of fundraising, but also in terms of awareness. We've got over 2,600 individual interactions with members of Congress by our research ambassadors. And through these, we've helped obtain and even increase funding for our National ALS Registry. And we've helped obtain and even increase funding for our Department of Defense ALS Research Program. And if you were watching, some of the best stories of 2021 to me were the way the Act for ALS sped through Congress and was signed by President Biden at the end of the year. And again, the research ambassadors had major roles in this. The Act for ALS is going to provide us with $500 million in new research funds over the next 5 years, both for research projects and also for expanded access. The research ambassadors have helped us improve our study designs. So in 2016, we had a conference of ALS researchers from all over the world. It was called the Early House ALS Clinical Trial Guideline Conference. And the result of this was a paper, an evidence and experience-based guide for optimizing the designs of future ALS trials. Research ambassadors participated in this. And in fact, they had some incredibly good suggestions that made it into the final recommendations, suggestions about how to advertise and educate patients about new studies, how we should be compensating participants in our studies, how we should more timely notify people who participated in studies of their results, how we should always formally acknowledge and thank people who participated in research, how we should be publishing our results in open access form so that people with ALS can read them without having to pay, and how we should always be inviting patients to attend all our scientific meetings so they can be true partners in our research. They've also helped to improve individual study designs. And so they've been reviewers for different grant programs like Treat ALS and the DoD's ALS RP. They've interacted with a whole bunch of different companies on their advisory boards and changed the way those companies design their research trials. And you can see all the different groups on the right side of this slide. They've connected with individual investigators like Anne-Marie Wills at MGH and me to help me figure out how to run some of my clinical trials of supplements like Lunasin and Therakermin. And they've been spreading awareness of research. They've given over 1,000 individual speeches at support groups, over 700 interviews, blogs, and website posts. They've even helped us figure out better ways to advertise open trials. So, you know, we know that clinicaltrials.gov is a very comprehensive source for information on new research, but it's still not very user-friendly. And so our research ambassadors have had a role in helping us design the NEALS trial search engine, the IMALS ALS Signal trial search engine. They've given us the idea to create something called a NEALS trial concierge, a person who will answer a phone or an email if there's folks out there who are trying to find an open research study. And then we also got from them the idea to do the National ALS Registry's research notification tool. And I love this quote that was on Facebook from one of our research ambassadors. "I'm starting to see evidence that our efforts work. For the first time, our clinic is getting requests about trials from patients. I've been speaking to support groups around our state, and it seems to have piqued their interest. I'm working with our clinic to make myself available to provide information and guidance with the clinical trial process." So Rick was actually showing up to his ALS clinic on days when he wasn't even scheduled to be seen there, and just making himself available in the lobby to talk about research and to answer questions. And you know, our ambassadors are all over the internet. So, I mean, they're on webinars, they're in Facebook, they're in chat rooms, and they're even starting to formally mentor now other people with ALS and other caregivers, helping them to understand research terminology and the importance of certain design features, as well as clear up some common research misconceptions. And then, you know, one of the things I'm most proud of is our graduates are coming back now, and they're helping to teach and even lead the CRLI and the Peace Committee. And I mean, I'd love to see a day when they run most of this and we're just here as advisors. They're helping to educate the community in lots of ways that I never thought of. I never knew what a podcast was until a few years ago. And now the research ambassadors have started to do podcasts, which help people to understand scientific papers. They're actually participating in videos on Your ALS Guide. They've helped me to make the ALS Untangled program, which systematically assesses these alternative and off-label treatments with the goal of helping people with ALS make more informed decisions about them. The ambassadors have given me lots of ideas for new reviews, but just as importantly, they helped me to completely revamp our ALS Untangled website, and I think it's a lot more user-friendly now. And they're accelerating the regulatory pathway. We're all frustrated by how long it takes to get things, you know, through regulators like the FDA. So ambassadors, along with many others in the community, helped to create something called the ALS FDA Drug Development Guidance. They participated along with many others in the community in meetings over the course of 2021 and 2022 with Congress and the FDA. And these meetings were about the regulatory process and how it needs to be improved, and also specifically about a drug called AMX 0035. Many of our research ambassadors testified at a recent FDA hearing on this. And although the FDA's advisory panel did not vote the way we hoped they would, it was close. And we still think there's a lot of hope that we might get an FDA approval out of this. And if we do, I think it's going to mainly be because of the power of patient advocates. So, some expectations. What you can expect from us, the faculty in this program. Well, we're going to teach you about research, how to critique a scientific publication, what the pipeline looks like, what some of the barriers to success are, and where there are opportunities where you can help us to overcome these barriers through education and advocacy. We want you to participate in the monthly Peace Committee calls that Allison and Nadia lead. And there you're going to be presented with opportunities to engage in the research process. And from here forward, I think I speak for all the faculty that will be available to you if you have questions or you're running into a snag trying to do something related to ALS advocacy. Just reach out to one of us. We're happy to have you bounce your ideas off of us. What we expect from you is to be engaged. We want you to ask questions. We want this to be more of a discussion than a lecture series. There's going to be a paper that we want you to try to critique on your own. So that's some homework for tonight. And then tomorrow we'll go over it together as a group. I know it's not easy if you don't have any scientific training to read a research paper, but do your best and just try to star some of the things that you don't understand or some of the problems that you see in it. When this program's over, it's really important that you complete your evaluation form. The agenda that we have today is really not very much like the agenda that we had when we started this program. And that's because it keeps changing in response to suggestions from different classes of research ambassadors. So please fill out that evaluation and help us to improve. And we want you to embrace this idea of being a research ambassador. Put yourself out there, help other patients and families to understand and get excited about research. Help sponsors and researchers to design better trials and to spread awareness of the research that they're working in. Participate in the Peace Committee meetings and maintain your NEALS tracker. And we'll talk more about this, but on the NEALS website, we've got this thing that we call the tracker. And this is our way of trying to measure all the great work that research ambassadors are doing. Now, this is far from perfect, but many times, especially when we do these programs in person, they can be expensive. Like to run this in Clearwater, Florida, at the hotel that the Northeast ALS Consortium uses for its meeting, it's somewhere between $30,000 and $40,000. And so we usually have to reach out to sponsors for that money. And the first thing that sponsors want to know is, well, what's the evidence that this is doing anything? And so this is one way that we can show them that this program is having some success with the NEALS tracker. You saw the agenda already. And so I'll open this up to questions, but before I do, I just want to thank all of you. I know it's not easy to sit through, 2 5-hour sessions of lectures on Zoom, but it just, shows us how passionate and committed you are to helping with these issues that we have. I want to thank all the research ambassadors who are out there, and I know some of them are going to be participants in this. You're just so inspiring, all the work that you do. It's part of the reason why I want to keep doing this. The ALS Hope Foundation for putting this all together, and all the faculty. I know we're all stretched really thin, and it means a lot that you would spend, your Friday afternoon and your Saturday morning helping with the CRLI. So thank you. And let's see, just feel free to unmute yourself or type your questions into Zoom. See something that Jamie typed in, so many ways and opportunities to have your voice heard. And yeah, Jamie, that's a really nice way to put it. Again, thinking back to that first patient I saw and that helpless feeling that I had, I've always wanted to find new ways to empower people, to fight this disease. And I feel like education and advocacy are new tools that we can pass along that people can use to fight.